patients. So welcome to the 12th webinar. It's titled The Psychosocial Support for COVID-19 Patients. I'm Dr. Lynn Tjirare-Ookame. I'm employed by the Ministry of Health and also am a resident in the Masters of Public Health Medicine in University of Botswana. So these webinars are created to capacitate and update the healthcare workers on issues around COVID in Botswana. They are co-organized by the University of Botswana, Ministry of Health and Wellness, Botswana-Harvard Partnership, and the Rutgers University. So if you wish to join the mailing list, please do email Robert at rmumakwa@yahoo.com. So the sessions will be made available for you. Please do mute your microphones. If you have any questions, please do post them in the chat function. We have a moderator who will be monitoring the questions. Please do participate in the feedback surveys at the end of the sessions. So it is my pleasure today to introduce Professor Tirelo Modie-Moroka, who is an associate professor at the University of Botswana in the Department of Social Work. He's a public health social worker who is broadly trained in the behavioral and social sciences and uses this breadth of experience to investigate various dimensions of health, behavior-related and related aspects. Her previous work includes research on social determinants of health and illness, stress and health outcomes, social support and social capital, women and youth in prison, heart adherence, families with severe and persistent mental illnesses, intimate partner violence, alcohol abuse, and cross-border migration and HIV risk. She has also taken part in the capacitation of HIV prevention project between the University of Botswana and the University of Pennsylvania, the USA. Professor Modie-Moroka is a recipient of the Social Science Research Council Fellowship Award for HIV, AIDS, and Public Health Policy Research in Africa. She is immensely experienced. Some of the other technical expertise lie in gender training, gender analysis, mainstreaming, and gender monitoring and evaluation. With the advent of COVID-19 in Botswana, she has been also working at the Masire Teaching Hospital, especially on the psychosocial welfare of employees and the patients of COVID-19, giving them services as well as the patients' families. She is also working on a collaborative research project on the assessment of the psychological dimensions of the COVID-19 pandemic among university students in other African countries. With all that said, Professor Modie-Moroka, welcome to the webinar session, and the floor is yours. Thank you.
Thank you very much for that generous introduction. I'm happy to be here to share experiences. And I just want to say that these are not like complete experiences, and I acknowledge that we are still in the process of learning, and we learn as we go, and at times we stumble and we rise again. My presentation is going to focus on some of the experiences that we have had since the advent of COVID-19, especially being placed at the University of Botswana Department of Social Work, and also working at the same time at Masire, working at different levels. It's no introduction that the COVID-19 is a pandemic of global proportions, and it has been declared a national emergency has been declared. So all of us are aware that the pandemic has influenced change at multiple levels, and it has also influenced specific behaviors and specific outcomes in terms of behaviors. And as such, public health authorities and other people are working around the clock to make sure that the outbreak of COVID-19 is contained. But one thing that we will soon learn is that the crisis is generating stress throughout the population, and as such, multi-level interventions are being tailored to try to respond at each level. One of the things that I want to speak to is that anytime there is a situation, whatever practice that we engage in is always shaped by the needs of the times, and the problems they present, and the fears that they generate, and the solutions that appeal at the time when the issue comes about. And also it speaks to the knowledge and skills that are available. And also it speaks to the knowledges and skills that may need to be enhanced and strengthened. So that is a quote that I bring from Ehrenreich 1985, page 13, but it speaks more to the current situation that we are in. There's still a lot of needs that are met, a lot of questions that are unanswered, and probably that is my own humility when I come before you. Every situation of this level requires us to understand these issues from what we call a modified social ecological model. And I'm sure that even with the Ebola outbreak, the social ecological model was still used because it looks at multiple levels, such as the individual, the microsystem, the mesosystem, the macro, and the chronosystem. And specifically with COVID-19, the first area of interest is the intersection of COVID-19, levels of the ecology that I have just mentioned, the stress process, and health outcomes. And so understanding COVID-related issues, mental health specifically, and what we will later call psychosocial support, requires us to understand the risks and patterns that appear at each level of the ecology. And then to also understand that this condition has brought in stressors, both internally and externally, and requiring people to adapt, to cope, to adjust, to seek new ways of behavior. And also there's been a lot of stress, like we have said, on the immune system across the board. And it requires us to understand deeply the intersection between those different aspects, because stressors influence successful and at times unsuccessful adaptation. The second issue that I want to address is that as stressors become more pronounced in the community, and especially with populations that we serve, and specifically the patients in the isolation ward, so to speak, we need to understand more deeply what psychosocial support is and what well-being is. So the word psycho by nature means internal. Functioning of the person. So when we bring in the word social, we are merely saying, how does the biophysiological functioning of the individual interact with the social, which is the interpersonal and the environmental factors that are all working together to either collapse the person's system completely or to help them move to the next level. So psychosocial support are services that are given by specialized professionals in hand with family members and other people. And it is the ongoing emotional, social, spiritual concerns that people raise in relation to the conditions that they are facing, but also looking at how those could be contained. When we talk about the provision of psychosocial support, whether it is to the employees of Tjirare-Ookame, as the case may be, or the healthcare workers, the frontline workers, or the COVID-19 patients. Broadly, we are talking about how to manage the emotional and psychological reactions that come from this particular condition, how to mitigate the risk and try to prevent more serious harm that may come through, and to reinforce some problem-focused and practical coping skills. And what you may actually realize is that, as I talk later, you realize that with stress coming in and being diagnosed with COVID-19, there's a lot of emotion focus and there's a lot of agitation. And people tend to take more emotional coping skills, which further deteriorate their conditions. So the idea of psychosocial support is to really make sure that we pull the person back to some problem-focused skills and to create a sense of safety. And the reason that is because it induces a sense of fear among people and to build some resilience. And as you may be aware, being diagnosed or living in a condition where there is COVID-19 kind of affects your strength emotionally. So it is important to also work on with the patients on resilience building and to work at social networks and social support systems. I'll talk about that later. And to make sure that the people that we have some level of psychological and social stability in themselves and in their relationships with other people. And as we work through these different aspects, we try to also move the people towards a sense of hope, a sense of dignity, developing strength and hardiness, a strong internal framework so that they can be moved more towards recovery. One of the things that we notice is that there is a lot of effect on the self systems or the self-esteem of the person, self-confidence, self-efficacy. So there is a lot of work being done in strengthening confidence, efficacy, and otherwise. And the other area that we are also noticing is that the psychosocial support team always needs accurate, up-to-date information because at times they are not able to, they don't understand certain things or they have received information from this person, but they're not sure how to verify it. So there is a very strong link between the psychosocial support unit and the isolation department in terms of cross-checking information that has come through. And the other issue that I wanted to talk about is the willingness and ability to continue working. We are working with people that are working in different areas. Some of are cleaners, some of them are working in the garden, some are in the isolation ward, but they are somehow employed here and there. And so what it means is that some of them will say, no, I want to stop work. So you want to provide support so that they're able to continue working in the isolation unit, or they continue to provide security services, they continue to clean, and they continue to do to make the gardens look nice despite the environment in which they are in. So we believe that, you know, a composite, a list of these aspects actually do help the patients themselves in promoting, you know, a positive diagnosis, so a prognosis, so to speak. So a wide range of multiple entry points. We have had to work with people in self-isolation, in quarantine, but mostly working with staff wellness, doing stress debriefing, working with patients at isolation wards. Now we are also working with students and then the general public. It's a basket. Many focus group discussions were held at the beginning, like in March, April, mostly targeting workers, gardeners, cleaners, people who work in the electric department, people who work in the, you know, in the electric department and different departments. And we have held focus group discussions with them. It's not only 10, but it's almost close to 100 plus people that we come into the focus group discussions. And we've also had 53 individual sessions in May and 87 in June. So when we receive people as referred, maybe from the Human Resources Department or from the isolation unit, we tend to work on an assessment. And mostly we start with the issue at hand, the presenting problem and the crisis that the person is facing. And at times we undermine this, but it may simply be a charger that the person left in the truck when they were taken to the hospital, and it extends all the way to serious issues. So we start off by attending and being solution focused and task-centered and doing what the person needs right now before we move to more serious assessments. So the assessments are mostly divided into four. Number one is the interpersonal assessment, the relationship with people at home, co-workers, and other people. And then the environmental is mostly with the employment, where they are employed, how are things going, and then also just their family, the community, and as you may be aware, the stigma is also there. Then a lot of work, actually deeper work, goes into the intrapersonal assessment because it really targets the person who is right sitting in front of you. But then there is the other one that we always forget is the biophysiological assessment. I'll talk about it later, but mainly is the person presents, yes, with COVID-19. But when you look at it, there are more other conditions that are always in attendance. And at times, we also begin to see issues of untreated health conditions that have been there. And there was non-adherence in the picture. So when they reach the isolation unit, the doctors begin to realize that this person was supposed to have been taking this particular medication. And there's a lot of work going into education and also connecting some of these factors that I've mentioned and trying to explain to the client the need for adherence and also to understand how the condition develops and what happens if it is not attended to as it should. So as we speak generally across the board and specifically with COVID-19 patients, we see a lot of mental health issues emerging at the top of the list. And generally with staff at the hospital, there's a heightened fear and panic around possible exposure. And also because of the work environment, there's a lot of disruption of social networks and social interactions with people being threatened at home that, you are working at the hospital, you bring us, COVID-19 and all kinds of other problems. Some have had children taken from them. You cannot keep this child because you are working at the wrong environment. So we are dealing with all those issues. But back to mental health. There's a lot of issues around fear, anger, and we see hostility and times rage and anxiety, panic, phobic, fear of everything. And at times when you look deeper, there are also issues around prior exposure to trauma. And mental health issues range very high among the people that we are seeing at Psychosocial. And then there are also issues around unexplained sadness, prolonged sadness, anger and loss of temper. And at times this anger is directed at times at frontline workers. And a lot of issues around moodiness and those kind of issues. And as such, there's need to strengthen, if I may say, the linkages between the care provided, but also to strengthen the mental health support and psychosocial support, and really going deeper into issues of cognition, perception. How do the people view themselves? How do they view other people who they work with? There's a broad group of people that we find. I'll just walk through them. These are different. When I talk about diversities, I mean there are men and women. Okay. And then there are international students, and then there are traders, and then there are migrants, some of them undocumented, some documented. Group of truck drivers, mostly all of them male. And there are also now we are beginning to see children coming into the picture. And with that also some of the risks associated with the associative behaviors that the people carry, smoking, alcohol, and other factors. And then substance abuse and addictions that do emerge. And then with also the risks and concurrent vulnerabilities, we see people, like I was saying, like who are on edge, so to speak, who react very quickly to certain issues. Even a glass of water that is delayed can actually cause some problems. So there are those that are on the low reaction, they don't speak much, they say, no, I will just keep quiet, there's no problem. But there are those that kick tables as well. So we are dealing with a wide range of people, and we need to understand their behavior across the board. One of the issues that we are also seeing is that the confession of conditions that were diagnosed before, but the person took medication once and then disappeared. And the issues around blood pressure, hypertension, and diabetes that later get treated by the staff at the isolation ward. But what it means also is that there is always an intersection between the untreated pre-existing conditions and recovery at times. And the other issue also, it's very important because we are dealing with stress and we are also dealing with recovery and we are dealing with moving people from a particular angle to another. We are seeing personality types that kind of, we can say they are compromising to the immunity. Like if you look at the list, it's mostly type A, people that they work in certain environments that are very pressured. They have to bring, send goods by a certain time. And so they are under a lot of intense pressure when they are not in the hospital. And some of them would say that this is the first time they've ever rested actually when they're in the hospital here. So what it means is that sometimes the work environment may actually challenge people's coping mechanisms and actually impact on their immune system. But at times the way they work is not necessarily recognized. We see, especially among those that have been working in those environments for long, a degree of volunteerism. In other words, I can beat, in a week, I can travel 3 times between Botswana, Lesotho, whatever, and Namibia and come back. But then it's putting pressure on the heart, it's putting pressure on the different systems of the body. So those are some of the things that we need to be looking at. The other issue is just briefly speaking to the healthcare staff also. They are right there empathetically engaging with clients. They see them, we don't, because we see them by phone, but they are the ones that are really hands-on. And we see, when we talk to them, we see compassion fatigue. We see shared trauma. We see simple things like missing family and wishing for some respite time. And so we have been talking a lot around engaging in self-care and finding time so that we can be compassionate, empathetic, and supporting others. But at the same time, we also need to be caring for ourselves and watching the patient's pain not at the expense of our own coping, and being a separate person even as we provide services. So we have been working with some of the staff that have come to the office to try to educate on issues of balance in life, exercise, relaxation, and also promoting positive cognitive appraisals. The other issue that is emerging very strongly is the issue of stigma out in the community, especially for those that have been released, that have recovered and gone home. We see stigma coming from workplaces, family members, community, and everybody who had access to some information. And we also begin to see self-stigma, where people are saying I think they are saying, but at times as we proceed, you realize that there's some self-stigma too. So we need to attend to issues of shame and attend to issues of strengthening social networks and noting that they can lead to loneliness and other things. So this issue of stigma, I think, is a major intervention point that needs to be worked at more seriously. I wanted to proceed also on the role of social support, strengthening our families. One of the lessons that we have here, a very good lesson, is that we have seen a lot of social support from family members, especially wives, especially children, especially relatives generally. There's been very good reports around. They're taking me, they're always with me, they always want me to feel good about myself. But we have also had intrusions of stigma from the community, where people will send messages to the person and say, don't come here, when they discharge you, tell us where they are taking you to, because we don't want to share space with a person like you. Those kind of things, we've worked around them and try to stabilize the person, especially when they are angry and bitter and going back and forth quarreling with whoever is stigmatizing them. So those are areas that we need to say there's some very few strained intimate relationships, but we've also seen stigma at work where people are told to take leave when they don't need the leave. So the other issue really around psychosocial support is to strengthen the psychocognitive behavioral features of the intervention, to maintain some balance between the bio, the psychosocial, and the spiritual. In terms of spiritual, we've had people saying, you know, I go to this church, my pastor has been supporting me. Or if the pastor is not supporting, we've been working around getting people to actually call the person and provide the support needed. Sense of mastery also is a major issue, the ability to believe that you can fight this condition with the help of the health people that are working with you. You can actually gain some control. But we also noticed that there's a lot of externalized locus of control and blaming systems, like they're delaying with my results, they're hiding my results, they're altering my results, and all those kind of things, where the person almost remains with no sense of power, but actually giving, you know, a lot of anger directed at labs that are bringing in the results. So those kind of issues are also done. Resilience, strength building is also a good one to work on. But there's also one we call post-traumatic growth after people have left the hospital, because we stay in contact with them when they're in the community. They will be, you know, telling you that, oh, I'm so strong, I can't believe I'm the one. You know, they're relating to others well, and there's more empathy. And some of them were saying that because of having come here, they are closer to their children, and there's more of protection as well, new possibilities, and more and different or more meanings in life. There's also some hopefulness that we see among those that are in the hospital and also those that have been discharged. Some coping also. So as people are moving through the psychocognitive variables, they are also being assisted at very close range by healthcare workers. And then finally, when it is all done, you hear the word recovery. So, but it comes from a long road. It is not a one-day work. So I don't want to go into the intervention domains. I was just listing a lot of the things that we tend to do, and that they are located within what I've already mentioned, which is doing assessments, finding antecedents, and doing a lot of cognitive retraining, restructuring the thinking of the person, changing the schemas. We may not be sure of this, but I just want to explain that a lot of our clients, they may come with the condition, yeah, COVID-19. But then when you start talking, there are a lot of life course issues. Some of them stretch back 20 years that have never been resolved. Unresolved grief, okay, disconnection with families, you know, families that are fractured even before they came to the hospital. So there's a lot of work going in behind the scenes in terms of life course therapy. And it also helps them when we talk to them and talk about high blood pressure, the biofeedback that they get from the medical staff. We also monitor what is the blood pressure, why is it high today, why was it young, you know, what was happening, what are your stressors, and we try to loop in and try to provide the support and knowledge that is needed. The other issue that I wanted to highlight is that surprise, for a long time, we don't know how to talk to clients without seeing them personally. And so some of the clients that we have had, they insist that they want to see us personally. And we are going around trying to explain that under these circumstances, we have been informed that we can only see them through telehealth. And I think it's a major intervention point. As we learn as we go, the first few weeks we were stumbling. We were not sure of how to move the client from one point to the other through WhatsApp, through, you know, even Zoom, through a lot of telephone conversations. But as we proceed, we are beginning to master some of these things, how to pose questions, how to move the client and not lose track. So telehealth is a key issue in this area. But it has been okay, because if there's a distress, if there's something that needs to be done, we can get it immediately by WhatsApp, and then we can slot the time and process the person properly. The other issue that I wanted to talk about is to reflect that probably the psychosocial support that is being given in the hospital, there could be a way to maintain that support a little bit as they leave the hospital. And it requires some strengthening of community linkages, the health system, the social work system, psychological systems, to try to strengthen the community psychosocial support system, especially to deal with stigma. The other issue is to really strengthen the discharge planning so that the linkages are open and referrals are done neatly and without the seams that we at times see. It would be so good to have a good referral system, and we know exactly who to talk to at immigration, who to talk to in which department, so to speak. And also just watching out for potential mental health issues after discharge. So those are some of the way forward issues. And I think one of the key ones, like I said, is strengthening telehealth and maybe training a large number of people to be able to utilize telehealth and innovate with clients. And it's a bit expensive to talk, because you can talk for an hour and 2 hours and the head aches after we have been talking forever and ever, and you are trying to get off the phone, but it's not possible on the other side. The other issue also is to strengthen self-care and support for healthcare staff and everybody, especially frontline workers, to establish referral systems, and not to get tired with what we call critical incident debriefing spaces where we can talk and meet, and then case conferencing between the psychosocial support unit and the isolation department, and to try to brief each other back and forth. And the other issue, well, is the timely, reliable information that we also need all the time. If there is a new development, I think it's important that the unit gets to know, so that we provide information that is current, and especially if it's empirical. And then to strengthen networks, I think that is very critical. Thank you very much. I hope I stayed on track, and I will welcome questions where available. Thank you.
Thank you very much, Professor. It was quite an extensive presentation. It's good to know that through your framework of biopsychosocial spiritual framework, the psychosocial support that our patients in Tjirare-Ookame have been experiencing, it's quite comprehensive. I'll just pose to you some of the questions that were on the chat initially before the presentation. So the first question pertained to how do we help someone while there is social distancing and putting on of mask? I think you did say something there pertaining to telemedicine. Maybe you can also expand. There was another question about, is there a plan to guide implementation of psychosocial activities in the community? The third question, is there psychosocial support for healthcare workers in general? We also would be interested to know that within the patients that you've interacted with, what has been the prominent psychosocial reactions that you have witnessed? And in other countries, we've seen that there's what they say is a preparation of healthcare workers before engaging in perhaps outbreak diseases like this one. I would like your thoughts to know, is that something that has been done in Botswana? Is it beneficial? And let me give the professor the time to answer those before we attend to the hands that are raised.
Concerning mixing social distancing and psychosocial support, I've already mentioned that we had to innovate because we are unable to see clients in person. So we had to quickly think through issues around Zoom, using WhatsApp, video conferencing. We use also telephone. We don't meet the patients directly. So far, we had learned to deal with that over the past 3 months, so to speak. We've been able to master some of it. But it also raises questions around equitable distribution of resources. There are clients that have actually access to Android phones. But I don't know what can happen in the event that in the future we have clients that do not have phones at all. So this is something that may have to be worked on for the future. But so far it has been possible because we have had actually 99%, probably even more, clients who have Android phones. So they have access to WhatsApp. The hospital provides Wi-Fi systems in their wards, so that we are able to talk to them throughout the time. There's no time where we cannot talk to the client. Is there a plan for psychosocial support in the community? Not that I am aware of. Actually, the only psychosocial support framework that I'm aware of is the one that was designed by the Department of Social Protection, but it was specific to orphans and vulnerable children. So where we stand now is that we are picking lessons from the OVC program and also picking lessons generally from what we know about biopsychosocial frameworks generally, how they can operate. But we cannot tell you that we are 100% there. We are just learning as we go, that how do we invoke the interpersonal support, how do you provide all those aspects. In terms of for healthcare workers, I am not aware of any. I think other people will also help me. But what we did is that we were having different critical incident debriefing sessions that were also meant to provide psychosocial support. And we are also providing one-on-one psychosocial support services. There are walk-ins. They come anytime they feel that there is an issue. Or if the human resources department feel that there is something that the person needs, they refer them directly to us. So in that way, to answer your question, I don't think I know of a written, manualized psychosocial intervention in the Ministry of Health. I'm not sure of that, but I think it's something that may have to be thought through going forward. Psychosocial reactions, I've already mentioned that we are seeing more of agitation, at times guilt, we are seeing fear, and at times we see anger, hostility, we see depression. A lot of it, especially through cognitive appraisals that tend to turn the dagger at the person. Like, people feeling very angry about the situation that they are in, but also the anger then gets directed at the labs and gets directed at frontline work. And at times there are those that turn anger inside themselves, but there are those that direct it at the ones that are trying to help them. And it's a major issue that needs to be attended to. But I think it's not something that is outside the confines of what cannot be handled, because the way I'm hearing it, even the people that are in the front line at the isolation ward, they're trained also. It's not only in strict biomedicine, but they're also trained in understanding psychological reactions. So at times before we receive these clients, they've already been assisted, especially just as they arrive. There is a lot of talking to the client, calming them down and making sure that they are settled and ready to move forward. The preparation, I think I have answered it.
Thank you, Professor. I saw Wetu, you had your hand up. You can unmute yourself and pose your question, if you still have the question.
Yep. Okay, hello, thank you. My question was to the professor that what are some of the silver linings that they have
Just hold
found
on,
out
Wetu,
from
we
this?
can't quite hear. Right?
Can you hear me? Can you hear me?
Okay, continue. We can hear you now.
Yes, my question was, what are some of the silver linings that the team, the psychosocial team, has found out? Because the professor was mentioning that they are using telemedicine. So what are some of the things that would guide the profession going forward as a result of this crisis? What are some of the things that they are learning, which would be good things out of the crisis? And my last question would be, in terms of the people that they are seeing, because for me, I work in the disability sector. It is very, very difficult for some of my clients to maintain social distancing or even use masks because of the disability that they have. And people who care for them, they have to they have to help them because there's no such social distancing that they can maintain because they need intimate care or close contact. So how would she advise in that area?
Thank you, Wetsu. I'll give the professor the time to answer.
This is Wetsu Mosoko, my classmate. Yes. Thank you very much. I think you are an expert in dealing with developmental and intellectual disabilities. You can share with us how you have been working on that. But maybe let me just go back to the silver lining issue. I think one of the areas that I mentioned was that we are learning that it is not all the time that you have to go and meet the client face to face. Yeah, it's possible to do some of this work by telemedicine, so to speak. But the other issue inside it is, you know, the ability to actually do it well. But the problem with that, without going back to problems, that is our clients often may not have access to the Android phones or to the services that are there. But I think the professions going forward is that in terms of budgeting, even at council level, even at hospital level, there could be some the development of telemedicine services, so to speak. I think we can find ways to create avenues. I was talking to one of the councils and saying you may have to create a room, a place maybe in the community where people go and sit and talk to the psychosocial support team without necessarily going to the offices. The other issue I mentioned, also a silver lining, is growth. And like I said, post-traumatic growth. People are beginning to see that they are strong. They see meanings in life. They have never before been threatened with a condition like this. But also just for some of our populations that are constantly on the run, working hard, not resting, not sitting down, always driving from one point to the other, we are beginning to see people that are relaxed now, sitting down and resting for some time without having to be driving, you know, one track to the next level and so forth. The other issue also, I didn't want to talk about this, but it's also, I will just talk about it within the context of confidentiality and say reunification of families, especially for populations that are transient, mobile populations that maybe desert their homes and they go. We are beginning to see people, we are able to trace families and bring them back to say, are you aware so-and-so is here? And we are able to rebuild family relationships in that way. And we are also beginning to see the like attachment between people that have never really taken each other seriously and trying to rebond and rebuild relationships. So those are some of the positive outlooks. We don't only have to look at things from a negative perspective, but we are learning also that even exposure to a situation like this can bring some good outcomes. And some of them is actually bringing back adherence into some people's lives, especially the ones that were supposed to take a particular medication 2 years ago and they did not take it, and now they're now under supervision to actually attend to their health problems. Those are some of the silver linings that we are seeing. But in terms of issues of social distancing, I don't know. What can you advise? Because you work directly with the clients. I don't know, maybe it's just a question of direct supervision, really, the way I see it, and making sure that, maybe you get more people in to try to supervise the masking and the distancing. But your situation is a bit different from everybody else's. So what have you been doing? Maybe you can help us. What have you been doing?
Yes, for the schools now, we have reopened for learners who can be able to manage the social distancing and also wearing of masks. So now the government had advised that for learners with profound disabilities, the reopening is going to be on the 4th of August. So I have been reading around, searching around to see how, when they come, am I going to assist them? How am I going to manage staff anxiety for people who will be providing one-to-one support? Do I have the proper protective clothing for people to feel safe when they help those kind of children with intimate care? And also from the parents also get relief when their children are here. But now the situation has reversed because now the children are still at home. So keeping a child with autism or ADHD or other profound disability in solitary confinement is very, very hard, because for now I'm experiencing that for children whom I didn't know that they had childhood traumas and other underlying problems, they are now becoming more and more, or they are starting to emerge. Yeah.
Thank you so much, Wetsu. I think what it requires you to do is to maybe start on devising or developing a new intervention that targets the families and trying to work through the stresses and the traumas that you have not been aware of, but also to try to educate the families in terms of the work that they can do with the kids. But with your staff, is the same applies. The same applies to actually doing the same thing that we did here at the hospital, holding training sessions, holding incident debriefings, having focus group discussions, and actually acknowledging their concerns and working through the stresses that and their fears as well. I think there is no way of going around it except to listen to the people that are being affected by the situation. Thank you.
Thank you.
Thank you very much, Wetsu and Professor. Do we have any participants who have more questions? Wetsu, you can put your hand down.
Yeah.
Okay, in the absence of questions, let me just say we are grateful, Professor, for your thorough discussion and enlightening psychosocial work that you are doing in Tjirare-Ookame and your team. We appreciate that really COVID-19 is a territory that no one has passed through, such that they have experience for us to look back. So I think Ms. Wetsu's dilemma is warranted, and the advice to be innovative is also warranted. I think every other department needs to have such an approach. And I think the psychosocial work that you have outlined, Professor, it's good. And I think it should also apply to other areas, not just COVID, because the things that you've testified you are unearthing in patients. I mean, all patients, COVID patients, all patients are the same, I guess. So I think to me, it's saying it's another territory that we should go to in all disease profiles, not just COVID. Thank you very much. Thank you. And everybody who participated today, thank you very much for participating. Please do remember to participate in the feedback survey. It helps us to know what more topics you'd like, what times you would prefer. It helps the planning to be more better. Thank you very much. We hope to see you again in the next webinar. Thank you.